So other ways of preventing falls and fractures for our patients, like Diane was talking about, we need to make sure their homes are safe and look at their environment that they're coming from. So we usually instruct our patients to, reduce the clutter around the home, use assistive devices when they really need it, and usually our PTOT evaluations do help with some of that to see whether they need a cane or a walker at home. Installation of grab bars in the bathroom, using non-skid mats or rugs. And then especially with those elderly patients on certain medications, they do get some dizziness. So getting up slowly from sitting or from lying down is going to be really important for them. And then wearing low heel shoes, rubber soles, things like that. So some medications that lead to falls most commonly include some allergy medications, anti-seizure medications, especially barbiturates, sometimes benzos. These I would include Benadryl, blood pressure pills definitely, because they could lead to hypotension once in a while. Water pills like Lasix, and any cardiac medications as well. And of course, your pain and sleeping medications can lead to a groggy elderly person that gets up and falls and fractures their hip. So I'd like to introduce Dr. Richard D'Alessandro, one of our ER doctors, to talk about the ER side of things.
So my name is Richard D'Alessandro. I am an emergency physician. I also have been involved in EMS since I started my career as a medical student. Currently, I'm also the medical director for United Ambulance. We've talked a lot about sort of the hospital side and how we treat these people, and hopefully you can understand that, this is a pretty important thing, and how there's a need to really address these. And you can also realize that these tend to be high-risk patients. They have a lot of medical problems. They tend to have other potential social issues as well, which we've addressed. What I really wanted to talk about is more of the EMS perspective, what we would do pre-hospital. For the most part, we're not going to do anything necessarily different. I mean, we already address injuries, stabilize, treat pain and everything else, but I kind of wanted to just sort of underscore some issues, and also realize that what you do and some of these other additional pieces of information that you can relay to the hospital really makes a big difference, because quite honestly, 99.9% of the people who work in medicine have no idea how people live. We see them in the office, we see them in the hospital, they come in with an injury. We don't really know how it happened. We don't know what kind of environment we're going in, where they're going home to. And so, particularly with people who have hip fractures, knowing some of that information early can really make a difference in potentially avoiding someone to go for rehab. Maybe we'll be able to get them back into their house. These patients tend to fall a lot. Sometimes it's because of medication, but I'm sure everyone who has spent any time in the back of an ambulance has seen elderly patients who are alcoholics, who are subjected to elder abuse, neglect, and you guys can pick up on that. We're not going to be able to pick it up in the hospital. We might. Usually if we do, it's on the tail end of things when they're home and social work's getting involved. So recognizing some of those things, can make a huge difference. It's a lot easier when you're in a home. You can really pick up on all the visual cues of, how safe they are, how not safe they are. So I think that's really important. A lot of times it's busy. You need to go, back into service. And sometimes that information gets lost in translation. So, you know, I certainly think when you have concerns, really making sure that information is passed on can really make a huge impact on that person's life. The other thing that I want to sort of underscore is pain control. These things hurt, they hurt a lot. I don't know, most people probably in the room have broken a bone at some point in their life. May have been like a finger or a toe, and those are kind of painful. These things hurt a tremendous amount. So really focusing on how you can make that person comfortable, how you can sort of, you know, stabilize them, get them out of the house in a safe way, in you know, the least painful way, really will make a big difference. Not only are these painful, but, you know, they know that their hip is broken or they're worried it's broken, and they also know that means there's a good chance they're not going home ever, certainly not for a while. So there's not only the pain, it's all the fear and stress associated with that. Who's going to take care of my spouse? Am I going to lose my home? All of these other issues. So the more you can make them comfortable from the get-go, it'll make the whole transition of care all the way through to discharge better. Early pain control really makes a big impact on every sort of clinical index that you look at on these patients. So with that, I'm probably going to jump around, so bear with me here. Basically what we're going to do today is limit the discussion to not every type of potential hip injury. We're really talking about these isolated hip injuries. So these are ground falls or trips. We're not talking about, you know, I fell off a ladder, potentially, you know, certainly most of the patients we're dealing with in this age group are elderly patients. They tend to be more high risk. Most of their falls are less than 3 feet. I think everyone would agree, you know, an 80-year-old person who fell off a roof is not going to come in as an isolated hip injury, and we're going to reserve that topic for another day. So these are pretty much our ground level falls and trips. So talking about aspects of history, certainly, you know, there are other issues. Most of the time these are pretty straightforward, but there are occasions where people can have falls for other reasons, as was stated earlier. Usually they're elderly patients, so there's lots of medications, lots of comorbid history, and, you know, most of the time these are just simple trip and falls, but sometimes they're not. And I think it's really important to, when you initially assess your patient, to make sure you have a detailed enough history and the facts all seem to suggest that this is a simple trip and fall. And when it's not, to delve a little bit deeper. A lot of times the patients will minimize their symptoms and, oh, it was just a little slip, no big deal, because they're afraid that if it's a bigger issue, they may find it's unsafe for them to go back to home. There may be elder abuse issues, and there may be substance abuse issues. I'm sure that at least at some point, you've had a grandma who came in who had one of her spells that the kids came by and she wasn't acting right, and you know, grandma's put a fifth of vodka away, and it happens a lot, and more than people realize. So again, asking the right questions. You know, you guys are in the house, you can see, you know, what the environment's like. Those sort of clues really make a big difference. So again, you are the people who are going to be the only witness to all of this, so really good information is important. Sometimes family is present. If they are, we strongly encourage them to either, if possible, have a family member come with the patient, particularly if there's a lot of fear or concern or agitation. Having someone familiar can really help the person sort of keep their orientation, make them less agitated, make them less confused. And make it easier to control their pain and positive for everybody. Family members can't go, please make sure they know where their parent is going or their family member is going, and at least find out if they're going to be coming or not, and at the very least get some contact information. We need that information, we need to speak with those people. Sometimes there's other medical history we're not acutely aware of that may determine whether or not this is a person who's an appropriate candidate for surgery. They may need surgery, and they may not have the ability to be consented for surgery or understand what's going on, and we're going to need those people to be involved. So having that information can save a lot of time on our part, getting the patients where they need to go and the treatment that they need. This is a blatant advertisement. United has a community paramedicine program. The state of Maine EMS has a pilot program. I think there's 10 or 12, is it 10? 12 programs. We have one of them. In the changing healthcare environment, roles of what is being provided for people out of the house has been changed. A lot of it's based on reimbursement, so there's a really increasing role for community paramedicine. And we've done a various spectrum of services, from safety assessments to helping patients with medications. Anyone can be referred to this program. It doesn't have to be healthcare providers. We have referrals in all our trucks. Right now, unfortunately, it's limited just to the LA area, although as of today, we've extended our service out to Leeds and Turner. And if things go well, we'll probably start extending that as well. So for those of you in Leeds and Turner, you'll be getting a lot more information shortly, I'm certain. So in terms of identifying hip fracture, this is pretty straightforward. Obviously, there's a trip and fall. They usually have pain related to somewhere, the hip, groin, or that area. Usually they're unable to bear weight. Usually they're not even able to get up. There's a lot of discomfort. There can be swelling and stiffness in the area as well. Classically, these extremities can be shortened and externally rotated, but that's not always the case. As Dr. Bush had alluded to, sometimes these femoral neck fractures kind of get impacted on themselves, and there's really not a lot of shortening or rotation. And those patients actually can move around pretty well. And you can be surprised how many of those are fractured when you think it's just sprained or bruised. So there's always soft tissue injuries associated with fractures, so there's going to be discomfort, and depending on how they got injured, that soft tissue injury may not be directly over their hip. It could be more towards the SI joint, the back buttocks, or off to the groin, and a lot of times that can be more painful than the fracture itself. Some patients can develop hematomas, and if they're more superficial, can cause a lot of swelling, distort the anatomy, maybe distract you from recognizing that there's a fracture. And sometimes they can be swelling in deeper tissue where you won't actually see any deformity, but can lead to some serious complications such as compartment syndrome. Usually those people have been on the ground for an extended period of time, and that just because they haven't moved, the pressure on the tissue causes a lot of edema and swelling. And sometimes these patients are on anticoagulants. There's a whole bunch of new anticoagulants on the market now. So if you haven't been familiar with those, it used to be just all warfarin, Coumadin. We now have all these A-band type drugs, Eliquis, Xarelto, Pradaxa, and I'm sure there's going to be tons more out. So it's important to ask for those type of things as well. For those who aren't familiar with compartment syndrome, basically all muscle groups are bounded by layers of fascia, which is it's basically like grizzle on a steak. It's a non-expanding fibrous membrane. It helps the muscles work more in an efficient manner. But what can happen is if there's damage in that, you can get bleeding or swelling. Because that capsule can't expand, the pressure increases, and then you can cause damage to the tissue. So classically, we talk about having pain out of proportion to examination. They can, as late findings develop, distal injuries to nerves and blood vessels, so the extremity distal can be, have a low pulse, it can look pale. They can have loss of sensation, motor function. So again, just recognizing good documentation, examination of the extremity above and below the area of injury, as well as every time the patient's are manipulated or stabilized. So we talked a little bit about this stuff already, but just to recognize that pelvic fractures can happen with or without hip fractures. Sometimes people can sustain pelvic fractures without a hip fracture. They can be quite painful as well, and sometimes there can be lumbar fractures. For the most part, hip fractures tend to happen in isolation. There's usually not a lot of other injuries, particularly when we're talking about, trip and falls. The problem is when we see the person in the field, we don't have a diagnosis. So it's important to recognize that it may be a hip fracture, but it may be a pelvic fracture. It may be one of these other things. So this is pretty straightforward. Obviously, any emergent life threats or compromise need to be addressed first before we deal with any specific treatments to any extremity injuries. Identifying the hip fracture, getting a good history we've already spoken about, immobilizing the injury, analgesia for pain, and then obviously any potential complications if they arise. So I want to talk a little bit about spinal assessment. This is sort of the bane of everybody. And what we have to recognize is, I have to apologize, I did have a slide that actually had the protocol on here, but apparently my technology skills were a little suboptimal and the slide got lost in translation. But you should all be familiar with that. If you look at it, it looks really great when you look at it. The whole right side of it is really straightforward, with pain on palpation and all these other things. The other side is what really gets us, right? It all talks about, the reliable patient distracting injuries. And that's always a problem. So if it was one or the other and you had an alert, calm, oriented, sober person, that's pretty straightforward. If they're obtunded or comatose, that's pretty easy too. The problem is it's a big spectrum, and the difficult ones are the ones in the middle. The point that I want to emphasize here is that most of these patients aren't going to have these type of injuries. There may be some. And the goal isn't to get it right every time, but it's for the patients that we can clearly, avoid any sort of immobilization, to do that. It's easy just to say, well, I just can't tell, and immobilize everybody. The problem with that is it causes a lot of pain, stress, and discomfort for the patients. Often the transport times can be quite long. Often by the time they reach the emergency department, they've been given some form of analgesia as well, and it makes it rather difficult for us then to try to clear these patients. In the end, what it does is obligate them to potentially unnecessary workup and delays before they get definitive treatment for their hip injury. So pain control, pretty much this is all following standard protocol. It's screen 15 and 16. If you are a ALS unit, then obviously fentanyl is indicated for those. If it's not available, consider the use of nitrous oxide if available. What I would say is that a lot of times we do get ALS called for intercept for pain control with these patients, which I think is perfectly appropriate. What I would like to offer to you is maybe thinking about calling for that earlier. Maybe even as soon as you get in the room, before you've finished your full assessment, you've been in the patient's house, you know what it's going to take to evac that patient. And you're going to have some time before you're ready to do that anyways. So if you recognize that, you may even want to think about calling right away. You'll cut down on some of the transport time, and then if the patient's safe and you can wait, leave them there and wait for ALS to show up and give the patient good analgesia before you even move them. In a perfect world, we'd like to evac the patient on a backboard or a reef stretcher. Sometimes that can be really difficult. Some of the homes are old, they're narrow hallways, steep steps. It can make it very challenging. Which is why I would argue that maybe good pain control prior to evacuating the patient would be a good idea. Plus, you may actually get extra manpower to do it. Sometimes, you know, the right way to do it is actually with some extra padding pillows, a scoop stretcher, and some extra straps, and keep the person on the stretcher in a position of comfort, rather than some alternatives. If the, well, you can read this, obviously. Just, you know, if there's no concerns about any associated injuries, you know, any way that you can transport the patient to the ambulance in a position of comfort is best for the patient. Extra pillows is always a good idea, splitting it. I would, you know, underscore that anytime the patient's manipulated, you really need to reassess the extremity for, you know, your CSMs. In terms of documentation, again, this is pretty much reiterating everything we've talked about so far. What caused the fall? If there's any concern for medical condition rather than a straight mechanical fall, that should be documented. Again, if you can make sure that that is relayed to the hospital staff. How long have they been down? How you packaged the patient, transported them, how they were moved into the bed in the emergency department, and all the other appropriate documentation regarding status of the patient, assessment of the extremity, and who you gave report to. I'm not going to read this, but this is a pretty standard radio report. And I'm going to skip that because we're running behind. So I'm going to ask Elizabeth to come up, and she's going to talk to us about the hip fracture program.
All right, so lots and lots of information thrown your way, and I'm just gonna throw some more, because why not? You're here, and I appreciate your attention just for a little while longer. So let's talk a little bit about the actual OICM hip fracture program and our system planning for improved care, because that really is the most important part, and this is the meat and potatoes of the program. So why a formalized program? Currently, and I've been told that this number is probably lower than it truly is, we see about 350,000 hip fractures annually nationally, not us in at Central Maine, but nationally. And we are in an aging population. So by 2050, there is approximated to be 650,000 hip fractures annually. Again, the 80% female, that is the most common, past 80 years of age is the most common age that we see. And women have a 1 in 7 lifetime chance, which is greater than breast cancer. So pretty significant. We have based our program off of the St. Francis Hospital OFC, and that's in South Carolina. And again, I love stats, so you can see here some of the stats that the program stats that they have done pre-program and post-program, and you can review those. But you know, as we stated, ED to incision is one of the most important things that we can do for the patient. Length of stay, we don't want them laying around, and then of course we always look at cost. So their outcomes, post, 80% of their patients return to independent living. These are really significant outcomes since when they started their program. Their mortality rate is less than 20%, post-op delirium less than 4%, a grade infection rate of less than 1%, and 100% patient satisfaction, which for Diane and I is one of the most important things. So our current metrics, from July of last year to February of this year, we have seen 86 hip fractures, which we hope to increase with your assistance. Our ED to floor time is 4.52, and our goal is less than 4 hours, so we're well on our way. ED to OR, 49 out of 86 cases was 22.18 hours. So we're starting with a goal of less than 24 hours from ED to incision, and we're meeting it currently. We want to get even less than that. If you remember, I said our motto is that we're never satisfied. Just because we set ourselves at 24, when we beat that, we're gonna set another goal lower. Our mortality rate, we haven't been able to track overall within a year, but we're working on getting that metric, and that 1.2% is in-house, so during their hospital stay out of the 86 cases. Post-op delirium rate 3.5, and discharge to home, we have some work to do, 14%. But we are always working on these metrics. So this is kind of our clinical pathway, if you will, and it does start with you guys. And as Rich said, it's so important. The information that you can get to us when you bring these folks in is of the utmost importance in starting their journey out on the right foot. So patient arrives in the ER. This is where we have standardized our order sets. So there's an order set for the ER to admit the patient, and then they get in touch with the orthopedist and the hospitalist, and that's where the discharge plan begins, as Diane stated. They get admitted to M2, Memorial Wing, second floor, which is also called the Oicm. Hospitalist consults and clears, prepares for surgery within 24 hours or less, and so there is another standardized order set. So the on-call doc isn't picking and choosing what they want to order for these patients. We've done best practice research, and we've put together standard sets for patient care. Hospitalist follows the patient throughout their entire stay, so they don't just do the clearance for surgery and then don't ever see them again, because as you've heard, these patients have a lot of medical conditions and a lot of potential medical risk factors post-operatively. Discharge planning, always important, and that continues on. And then the patient is discharged, preferably to home with home health, but we do have patients going to rehab, skilled facilities, and then they need to follow up with Central Maine Orthopedics as well. We do have a program vision. We want to be best in class. We want to develop a center of superior performance for hip fractures. Again, that is focused on the multi-specialty team approach, delivering value and quality through reducing variation. And reducing variation means we're using those standard order sets that are based on best practice. Here's a list of our goals, some of which I have mentioned with the time frames, but we also want to enhance their functional outcomes, reduce the nursing home placements, increase patient and family satisfaction. Another one of our big things that Diane mentioned, we have put together patient education, patient and family education for our hip fracture patients, and they will receive that right on admission, and that has been created by our own multidisciplinary team. And we really want to become, and we will become, the first formalized hip fracture program in the state of Maine. So there is not one currently, and we're here to tell you that we're going to be the first. It's a very exciting time for us. We've been working about 3 years on getting everything in place to make sure that this was right for the patients that we were going to bring in. So this lists some of our success strategies, which when reading over them, I hope you've been able to hear throughout our presentation. We're working on things such as reserved OR time. There's a big OR initiative going on in our organization, and we're working with them on that. We do have dedicated beds on the orthopedic unit, and they are all telemetry capable, and that's another important part. We designed our unit 5 years ago, all private rooms, very aesthetically pleasing, very hotel-like, and they all have telemetry capability. And that's important, especially for these type of patients with the medical conditions that they may have. We do aggressive therapy. We've trained our nurses and our CNAs and our therapists to not be nice and say, yes, you have to get out of bed. It is day of surgery, but we need you to get moving. It's gonna only benefit you in the end. And then again, early discharge planning, and we always will look at our outcomes. We're always gonna be pulling our continual outcomes and making changes based on what the numbers are telling us. So in summary, preventing hip fractures and their causes, as Dr. Gumati stated, is a really important step. And I did forget to mention too, part of this hip fracture program isn't just about taking care of them after, but it's about the prevention part, which actually needs to start well before they're middle-aged. It needs to start actually in the elementary schools. So I would actually like to see some of my nursing staff getting out into the elementary schools and the grade schools, high schools, and talking about osteoporosis and prevention and nutrition. So that'll be another component of our hip fracture program once we get things more solidified. Hip fractures are common, they're debilitating. Our goals of treatment are to limit pain and help the patient return to normal activities. Caring for these patients, it does require knowledge of the pathophysiology of various hip fractures, and that's what we have the surgeons for. And then developing a hip fracture program at the Orthopedic Institute will help to reduce complications and generate better outcomes for our patients. So with all of that information, I would really encourage you all to take this back to your peers, in your work settings, in your communities, to your friends and families, and just talk about it, because it is important. And we've done a lot of work, put a lot of work in place to make sure that these patients get the optimal care.